Welcome to this month's BNTP. Today we have Professor Stephan Schug presenting on update on neurophysiology of pain. Reminder to all connections to please mute your microphones and cameras. We will have time for questions at the end of the presentation. I'll now hand it over to Professor Stephan. Thank you.
Yeah, hello, good afternoon to all of you at all these different sites. I want to give you a brief introduction on current thinking on the physiology of pain, and then follow this up with some information on what this means for pharmacological treatment of pain. So you all will remember that the original definition of pain was an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And that implied a rather mechanistic view of pain, but already involved emotional as an additional quality. So if you look at a picture like that, you can see as well the tissue injury, as you can imagine why there is significant pain in this gentleman. And this is how we all regard pain usually. This type of pain has been studied for many years. This is from 1600, Descartes, where he actually describes that if fire A touches foot B, then information travels up to the brain F in the same way as pulling a rope would ring a bell in the brain. Now, this mechanistic view is still governing the thinking of many people dealing with pain, and is possibly one of the biggest problems in trying us to get a better understanding of chronic pain. Because this model was a very simplistic one, where there was nociception, and then the nociception caused pain in the same way as activating a fire alarm would actually inform the fire brigade about a fire. Now, this concept of a rope linking more or less the injury to the brain was challenged for the first time in 1965, when Melzack and Wall published in Science the idea of a new theory of pain mechanisms, which then became the gate control theory of pain. I don't want to go into the complexity of it, but I think this is a nice Australian-based cartoon which shows you the nice kangaroos being the touch sensation, for example. And if the gate is overwhelmed by the kangaroos, then actually the nasty crocodiles of pain don't get through the gate. And this was the first time that people were actually suggesting that it would be useful to realize that pain is not a direct result of nociception, but can be modified. We know that this is much more complex than initially anticipated by Melzack and Wall, and the current thinking we have on top of the beta stimulation stops A delta in throughput is that we know now that there is a complex descending system of pain control inhibition, which goes from the cortex, originates primarily periaqueductal gray nucleus raphe magnus, and ends on the dorsal horn of the spinal cord, and that major inhibitors here are endorphins and enkephalines, but then also substances which would bind to the alpha-2 receptor like noradrenaline, and to the 5-HT receptor such as serotonin. In addition, you see here factors which can actually influence the appearance or the strength of the descending inhibition. You know that placebo is in particular powerful in pain, and the reason is that we are activating our descending inhibitory pain pathways when we are expecting the effect of a painkiller, and expectation is one of the driving forces behind placebo effects. With regard to exercise, we know that physical activity strengthens descending inhibition, and that's one of the reasons why in most modern pain management programs, physical activity, aerobic exercise plays an important role. You have then relaxation, and that is very clear because we all know that if we are less stressed, we will perceive less pain, and that relates also to sleep hygiene. It explains the importance of clinical psychologists in this setting. Last not least, there is stress, and you will possibly say, but that contradicts what you have said so far. But this is not the day-to-day stress we are all experiencing in our daily life. This would be life or death stress, and in these situations, it makes actually sense that you switch on descending inhibition, and you have possibly heard about that in battlefield situations where soldiers have horrific injuries but don't feel the pain, or you have seen it in the emergency department where patients after severe accidents, sometimes for the first 30 or 40 minutes, will describe no pain despite the significant nociception. This concept is now called stress-induced analgesia, and I use it here to illustrate that there are situations where there is very severe nociception, lots of fire, but the inhibitory system in the black box CNS is powerful enough to stop the sensation of pain. So like our fire alarm system is out of order. Now this was the inhibitory system. It took a little bit longer than 1965 to 1983 when Clifford Wolf actually discovered evidence for a central component of post-injury pain hypersensitivity. You see that here, published in Nature in 1983. And this was the start of research which has now resulted in us realizing central sensitization as being the other important driver of chronic pain beside inhibitory pathways. The history of central sensitization is that Clifford Wolf initially discovered more or less a very simple flexor nerve, but it then became obvious very quickly that this could actually be transferred to the spinal cord, to the pain, to the thalamus, and last not least to cortical structures. And we know now that on all of these levels, there is central sensitization. What that means is that you will have pain states where there is no nociception, there is no fire, but very realistic pain. And a classical example is phantom limb pain. You have not even a limb to have the nociception in, but the excitatory mechanisms of central sensitization in the CNS are powerful enough to create pain, which is pain without nociception. And this illustrates finally that the Descartes model of a direct linkage between nociception and pain is really not valid. You can have no pain with nociception in stress-induced analgesia, and you can have pain without nociception, for example, in phantom limb pain. So what that means is that if you look at a classical pathway, we have here the A-delta nociceptive pathway, and it is actually leading to a wide dynamic range neuron, which is also under the control of inhibitory interneurons. When you stimulate a nociceptor with high or low temperature, with mechanical force or chemical irritation, the nociceptor will fire, the wide dynamic range neuron will transmit pain to the brain. In parallel, you have low threshold A-beta mechanoreceptors which respond to touch, and they will tell the brain that we are touched, but the cross connection is too weak to actually activate pain pathways. If you are now in a situation where you have central sensitization with a wide dynamic range neuron which is super active, then the input from nociceptors will be amplified, and that means that you actually get hyperalgesia. A painful input will be more perceived as more painful. And in addition, the input through the low threshold mechanoreceptors by crosstalk to the wide dynamic range neuron will now be sufficient to activate pathways to the brain which are related to pain, and therefore touch becomes painful. The classical example of allodynia, which you will see in many patients with neuropathic pain, for example, postherpetic neuralgia, and so on. In addition, and this is rather new, we have realized in the last 10 or 15 years that microglia, previously thought to be only a structural skeleton of the nervous system, has actually a major function, and activated microglia through chemokines and cytokines can actually lead to increased central sensitization, and that explains why at the moment there is quite a lot of interest in researching glia, active pharmaceuticals, and PEA you have possibly heard about, and low-dose naltrexone are attempts at the moment to calm down hyperactive glia in central sensitization. But this research is at very early stages. Last not least, we need to realize that, for example, here a patient with severe CRPS that looks to all of us like inflammation and osteomyelitis. But if you think about it, this is also the consequence of central sensitization, with now antidromic stimulation from the central nervous system to the periphery, releasing in the periphery substances which are inflammatory and thereby causing neurogenic inflammation, meaning that even such symptoms do not contradict central sensitization. Last not least, in phantom limb pain and in CRPS, we have now very good evidence that central reorganization of the cortex, the somatosensory cortex, occurs. And you see here a classical example of, usually on the somatosensory cortex, the mouse being very separate from the hand. But when you have an amputation with phantom limb pain, then actually the cortical representation of the mouse is invading the cortical representation of the amputated hand. And if you have this type of invasion, you have phantom limb pain. If you actually, by training, for example, and there is now increasing interest in this, moves the localization back, you will actually lose phantom limb pain. So cortical reorganization, glia activation, and central nervous system pathways are all contributing to that. And you see here another example. This is the normal representation of a hand in the somatosensory cortex. This is the representation of a severe CRPS, like the lady I showed you before, where there is nearly no cortical representation. If you now use cortical reorganization training for 12 weeks and do a functional rehabilitation, you see you can re-establish the cortical reorganization of the hand, and in parallel these patients gain hand function, they lose allodynia, and they lose their pain of the CRPS. So the cortex plays an important role too. Therefore, there is now a dramatic shift in thinking, which started possibly around 2000, and this is one of the first quotations on this. Persistent pain should be considered as a disease state of the nervous system, not a symptom of some other disease conditions. And just to take you back, in principle, when we talk about pain, we regard pain as a symptom. But in chronic pain, the central sensitization disorder becomes the disease, and therefore chronic pain is a disease in its own right and no longer a symptom of something else. And this has been acknowledged in the definition of pain, because they added this sentence, or described in terms of such damage. So they went away from actual or potential tissue damage and accepted that description in terms of such damage is sufficient to describe pain, and that's, for example, why phantom limb pain is now a pain diagnosis and not a psychiatric diagnosis, which it was in the past. Now, I cannot formulate that better than Clifford Wolff in a recent review, where he wrote, "We all experience pain as arising from out there, and in consequence imagine that it is actually triggered by noxious stimuli where we feel the pain. Central sensitization reveals, however, that this in many cases is a sensory illusion. Specific alterations in the CNS can result in painful sensations occurring in the absence of either peripheral pathology or noxious stimuli." And I think this is a very good description of the phenomenon, that the patient and the doctor sees the pain as being in the arm, but it is actually a sensory illusion created by central sensitization. He also wrote very wisely that these notions were generally not very well received initially, and they are still not very well received by many physicians who simply think that if you have no pathology, you have no nociception, this cannot be true pain and must be something psychiatric. And so most clinicians prefer to use loose diagnostic labels like psychosomatic or somatoform disorder to define pain conditions they did not understand. And I think regrettably, this is not only true in the past. We still see a lot of, for example, insurance opinions and so on, where it is more or less expected that this should be a pathology or a nociception to cause pain. So a summary of everything I think we should consider from now on is that on the one hand, we have physiological pain. And physiological pain is pain with a biological function, and it is the pain we usually know. The overarching concept is that we have a fire and a fire alarm, so there is nociception. This can be either simple nociceptive pain, but the moment you have a tissue injury, it becomes inflammatory pain. But both of these have a biological meaning. So they are an early warning system to protect us from noxious stimuli, and there are, once inflammation has occurred, a system where tenderness promotes repair. This is always moving without me touching it, very strange. So this is physiological pain. This is a pain we are all used to. It is a pain which occurs in acute tissue injury, but it is not the pain we are seeing in many, many chronic pain patients. What we see in chronic pain patients is called pathological pain, and this can either be neuropathic pain or CNS dysfunctional pain. And the overarching unifying factor is that you have no fire, no nociception, but you have a fire alarm. In neuropathic pain, you will realize that this is now clearly defined as something which requires a disease of the nervous system or a neural lesion. It is typical that neuropathic pain has positive symptoms, pain, allodynia, hyperalgesia, in the same area as negative symptoms, sensory loss, motor deficit. Think about somebody who is a paraplegic. They have pain below the lesion, which at the same time is positive pain, but they have no sensation at all. The reason is either peripheral or central nervous system damage with abnormal central processing, and this is clearly a maladaptive low threshold pain. It has no longer any warning or biological function, and it is a disease state of the nervous system. Furthermore, there are patients who present with what we called in the past CNS dysfunctional pain, and that means they don't have a neural lesion. They have no inflammation, but they have positive symptoms. And we understand now that these positive symptoms of spontaneous pain and pain hypersensitivity, for example, in fibromyalgia, are the result of abnormal central processing. And this abnormal central processing is very similar to neuropathic pain abnormal central processing, but here we lack a neurological deficit, we lack a lesion or disease of the nervous system. And this has really resulted in a discussion in the IASP that we need a third descriptor beyond nociceptive, inflammatory, and neuropathic pain. And the idea was altered nociception, no evidence of actual or threatened tissue damage or lesion of the somatosensory system. And there were actually 3 candidate terms, and I can tell you that only a few weeks ago, a decision by the nomenclature committee was made to call this pain nociplastic pain. And this is now, beside nociceptive inflammatory and neuropathic nociplastic pain, the new statement, for example, for conditions like fibromyalgia, irritable bowel syndrome, interstitial cystitis, and so on. So altered central sensitization without an underlying nociceptive or neuropathic injury. I want to come to a conclusion here, and I hope I was able in this relatively short time to challenge the traditional specificity theory of pain perception. We have learned that pain is not always the result of and directly proportional to peripheral nociception. Central sensitization explains the dramatic changes we see in the somatosensory nervous system, and it is responsible for many of the often bizarre findings you make in patients with chronic pain. And I think now that this is a major contributor to many chronic pain conditions, and we have gone away from CNS dysfunctional. We are still using the term pathological. The Americans want maldynia, but the IASP has decided in favor of nociplastic pain. These chronic pain states are not the symptom of an underlying peripheral pathology, but the result of a dysfunction of the CNS long after the healing of the peripheral pathology, and thereby trying to search for and repair peripheral pathology in these patients is an approach which is doomed for failure. With this, I want to leave alone the pharmacology, and I had another one here for the, where's my other one now? I had prepared it before. Just a second. Can't get out.
Alert from no backups for 14 days.
Where is this now? Why is the other lecture not on the share anymore? Sorry, I need some technical assistance here. I had this before, 2 windows here to share, and now it's no longer there. How can I get that back? Lots of adverse effects all over different organ systems. Next slide. And the magnitude of these side effects of anti-inflammatory drugs is actually significant. You can see here a meta-analysis from the group around Moore and McQuay from Oxford, where they looked at 1.3 million patients taking non-selective NSAIDs for at least 2 months. And 1 in 5 has a visible ulcer, 1 in 7 gets symptoms from the ulcer, 1 in 150 has a bleed or perforation, and 1 in 1,200 dies. So while these events are not super common, they are nevertheless so significant that they can actually have very bad consequences for our patients. Next slide. So you remember that around 20 years ago, the discovery was made that we have COX-1 and COX-2 inhibitors. and that actually, in contrast to the previous assumption that we need to block COX-1 and COX-2 to achieve anti-inflammatory effects, we know now that actually COX-1 is more a normal constitutive enzyme and does all the good things like protecting the stomach, the kidney, the platelet function, and COX-2 is the inducible enzyme which causes inflammation, pain, and fever. Next slide. What we also realized is that in a lot of situations, the COX-2 has also a constitutive function, and the two which caused a lot of problems initially were the endothelium and the kidney. Next slide. So if you look at what did we get out of COX-1 versus COX-2 inhibition, you see here a large summary analysis. What is happening now? A large summary analysis of risk of hospitalization from gastrointestinal bleeding. And you can here see that NSAIDs on average have 5 times the risk of no use, and COX-HIBs are very close to non-use. So the idea that COX-HIBs are reducing GI ulceration by not impairing COX-1 was a correct one and could be confirmed. Next slide. And if you look at the other issues, there is this big concern that COX-HIBs might cause cardiovascular adverse events, and you can see here a meta-analysis again from the Oxford group. Blue are GI bleeding differences, salmon color is cardiovascular event differences, and if you look at the line of equality at 0, then all COX-HIBs are on the left side for GI bleeding differences, because there is no question that this is a uniform effect of COX-2 inhibition. But you see also that for cardiovascular events, there was rofecoxib, my red arrow, which is actually causing or caused significant problems and led to the withdrawal of rofecoxib. But on the other hand, the currently available substances like celecoxib and parecoxib have, if anything, favorable cardiovascular outcomes in comparison to non-selective NSAIDs. And you see the other one, which is still on the market, etoricoxib, has a little bit a hint of a cardiovascular event rate difference. And what concerns me about this substance is that chemically it's very close to rofecoxib, so it could be that there is a similar problem developing here. Next slide, please. In conclusion, NSAIDs and COX-HIBs are useful non-opioid analgesics, in particular in any conditions with an inflammatory component. We know that the traditional non-selective NSAIDs and the COX-HIBs have similar efficacy in acute and chronic pain, but the adverse event profile of the non-selective NSAID is not very good, in particular in the elderly, in patients with previous GI, cardiovascular, or renal risk factors. Next slide. COX-2 selective versus non-selective NSAIDs are clearly advantageous with regard to GI adverse events. Therefore, we can use them at patients at increased risk of GI ulcers. They do not cause bronchospasm in aspirin-induced asthma, and therefore we can use them in these patients too. And there are now data, for example, the Precision trial recently published in the New England Journal of Medicine, which show that they might have an advantage with regard to renal adverse effects and are clearly not worse than non-selective NSAIDs with regard to cardiovascular events. Next slide. For neuropathic pain, which we already discussed, there is a new definition since 2011, and it requires a lesion or disease of the somatosensory system. It can be either caused by peripheral nerve injury or disease or by central nerve injury or disease. Next slide. And you are all familiar with the many neuropathic pain syndromes we see in our practice, from simple peripheral neuropathies, where diabetic neuropathy is possibly the most common one, to post-traumatic ones, where sciatica is possibly the most common one, and then the central ones after spinal cord injury, stroke, and multiple sclerosis. Next slide, please. There is possibly one paper you only need to read if you want to treat neuropathic pain, evidence-based today, and that is a paper in Lancet Neurology 2015 by the Special Interest Group Neuropathic Pain of the IASP. And if you look at the names there, there's everybody on there who has really a big name in neuropathic pain. Next slide. What this group is suggesting, based on a very careful meta-analysis, that there are strong recommendations for first-line drugs, and the three groups of first-line drugs are gabapentin and pregabalin as the anticonvulsants, SNRIs, duloxetine and venlafaxine, and tricyclic antidepressants such as amitriptyline and nortriptyline. And you can pretty much start a neuropathic pain patient on any of these first-line treatments, and I suggest to make the decision which one to use, dependent on comorbidities, age, and risk factors. There are then second-line treatments, and here the two which are available in Australia is lidocaine patches for peripheral neuropathic pain in a localized area, for example, postherpetic neuralgia and diabetic polyneuropathy. Highly effective, minimal side effects, and the authors actually in the review write that this should be regarded as a first-line treatment in patients with significant comorbidities or in patients with significant polypharmacy already. Then you have tramadol, which is superior to other opioids with regard to effect in neuropathic pain and with regard to abuse properties. And now, the 2018 tapentadol should belong here too, because it is also a very useful second-line treatment. All other strong opioids, and you see that on the bottom, are only recommended as third-line, and that is primarily due to the problems with opioids in chronic pain, and I will talk about that in the last part of my lecture. Next slide, please. So antidepressants are best documented. They have the best NNT, but bear in mind, many of the trials are very, very old. Amitriptyline and nortriptyline. Amitriptyline is possibly the best investigated. They need to be started on a low dose because this increases compliance, and you know you have many contraindications and adverse effects. The SNRIs, venlafaxine and duloxetine, are interesting new options, in particular as they are not as sedating and can therefore be used in patients who would otherwise be too sedated. Next slide. Of all the previously used anticonvulsants for the treatment of neuropathic pain, only pregabalin and gabapentin have really stood the test of time. You know that these two drugs bind to the alpha-2 delta subunit of voltage-gated calcium channels in neurons, and by reducing calcium influx, they are reducing the release of excitatory neurotransmitters in pain, in particular glutamate. Next slide. What is the difference between pregabalin and gabapentin? The most interesting difference for us in practice in Australia is that pregabalin is funded by the PBS and gabapentin isn't funded. From a point of pharmacology, pregabalin is significantly more potent than gabapentin. Pregabalin has a non-saturable pharmacokinetic, so you double the dose, you get double the plasma concentration, while gabapentin pharmacokinetics are saturable. Pregabalin has a higher bioavailability, and due to the longer half-life, twice daily dosing is sufficient. The exchange rate is 6:1, so for 6 milligrams gabapentin, you have to give 1 milligram of pregabalin, and often you get better analgesia out of the pregabalin at that dose due to the better bioavailability. Next slide. Lidocaine patches, 5%, are now available in Australia, although regrettably not yet on the PBS. They are an extremely effective treatment, in particular of allodynia and neuropathic pain of postherpetic neuralgia, but we are using them increasingly off-label also for diabetic polyneuropathy, and in particular for trauma-related neuromas and other localized neuropathic pain after burns in scar areas, for example. The amount of lidocaine is relatively high in the patch, but the absorption is so low that you do not get relevant systemic blood levels, and therefore you have no systemic side effects. The effect is a regional suppression of ectopic activity by lidocaine blocking sodium channels, and secondarily, the device is actually a very nice cooling patch, a gel patch, and that has some anti-allodinic properties in itself. So a treatment which is possibly underutilized, in particular in elderly people or in people who can't tolerate systemic antineuropathic medication. Next slide. I want to briefly mention cannabinoids because it is everywhere now in Australia. The data on cannabinoids in neuropathic pain are totally disappointing. This is a meta-analysis the group performed which shows no advantage over placebo with the use of cannabinoids. And on the basis of this and many other findings, the Faculty of Pain Medicine of the Australian New Zealand College of Anaesthetists is not supporting the use of cannabis or cannabinoids in any pain indication, in particular not in neuropathic pain. Next slide. This is in line with the recommendations by the Special Interest Group Neuropathic Pain of the ISP, which also make a weak recommendation against use because poor or no efficacy and risk of adverse effects. Next slide, please. So what about opioids? I want to finish this lecture on the use of opioids in chronic pain, in particular because this is such a big, big problem in Australia. Next slide. You know that this all came initially up in the United States, where after initially nobody wanted to use opioids for chronic pain, then suddenly everybody was on opioids for chronic pain, and the New England Journal of Medicine had this shocking paper, A Flood of Opioids, a Rising Tide of Deaths, which really highlighted the problem in the United States. Next slide. If you look at it, if you go just back very briefly, if you look at it, we had the United States had in 15 years more than 165,000 people dying from overdoses of prescription opioids. This is not heroin. And in 2014, in 1 year, the last year of these statistics, more than 14,000 people died from overdoses involving prescription opioids. Next slide. Now, regrettably, we are in the red like Australia, Canada, like the US and Canada. You see, these are the countries with the highest per capita consumption of opioids in the world. Next slide. And this is really a problem, and we have recently published a paper on the opioid epidemic and a perspective from different continents, where I highlighted the Australian situation with two other authors highlighting the German and the Canadian situation. And if you are interested in this, this is available in Pain Reports, a new publication of the IASP. Next slide. What we saw is that around 1990, there is suddenly a dramatic increase in pink of overall use of opioids in Australia. And this was in particular due to, in green, oxycodone, and now increasingly in this bright blue due to fentanyl. And this is exactly in parallel to the United States, where you had initially the oxycodone and then the fentanyl problem. Next slide. This has resulted in headlines like this in the West Australian: prescription drug addicts use doctors like dealers. Next slide. And if you look at the results, we see exactly what we saw in the United States. Here is in dark heroin, and in gray pharmaceutical opioids, and between 1998 and 2007 there was a complete reversal. Heroin disappeared but got much less, but in parallel pharmaceutical opioids, oxycodone, fentanyl, hydromorphone became actually the most abused substances. Next slide. This is also explained by the black market value. This is from the West Australian Ministry of Health, so this is not my invention. You can see here that prices are up to $1 milligram for oxycodone. Next slide. And regrettably, I live now in the overdose capital of Australia, so we have the highest rate of accidental fatal overdoses from prescription opioids among all capital cities in Australia. Next slide. So the big question is, next slide. So the big question is, why is that related? And the data are showing it is clearly related. You see here in red, the consumption of oxycodone per million population per day in the daily doses. And you see this continuous increase from 2001 to 2011. And if you see the oxycodone-related death in Australia, you see an exactly identical parallel increase. Next slide. Now, what are we dealing with here? I think the big issue is that while we are prescribing too many opioids to chronic pain patients, at the same time, opioids are rather ineffective in the treatment of chronic pain. So this is from the Agency of Healthcare Research and Quality of the US, and the conclusion is evidence on long-term opioid therapy for chronic pain is very limited, but suggests an increased risk of serious harms that appears to be dose-dependent. Next slide. So we are actually not helping our patients, and this is also confirmed by an excellent study from Denmark, where they looked at the whole population of Denmark. They have an excellent health database where they can do that. Next slide. And what they could identify is opioid treatment of long-term chronic non-cancer pain does not seem to fulfill any of the key outcome goals. So the patients get neither good pain relief, nor improved quality of life, nor improved functional capacity. Next slide. And this is pretty much a consistent finding. And in addition, we know now that if we give high-dose opioids to patients who have chronic pain due to central sensitization, we are causing opioid-induced hyperalgesia. And it looks as if, in particular, the issue of glia activation plays an important role here. Next slide. So what has gone wrong? I think what has gone wrong is A, that we have tried to treat pain caused by central sensitization with drugs which are very effective for nociceptive pain, but are actually increasing central sensitization. And secondly, we have ignored what we now know, that chronic pain is not only biopsychosocial, but the order is actually socio-psychobiological. And that makes obvious that treating such a condition with a medication is doomed to failure. You have possibly seen the new curriculum of the Faculty of Pain Medicine, and we have actually put into it that we are now following a socio-psychobiomedical philosophy of this curriculum. Next slide. So the Americans have gone the extreme step in now involving the Center for Disease Control, which is really looking after epidemics in dealing with opioids. And they have made very clear guidelines. Non-pharmacologic therapy and non-opioid pharmacologic therapy are preferred for chronic pain. If opioids are used, they should be combined with non-pharmacologic therapy and non-opioid pharmacologic therapy. And before you start patients on chronic on opioids for chronic pain, you need to think about realistic goals, and realistic goals are more important for function. So if you do something with a chronic pain patient, the result needs to be improved function, improved ability to be physically active, and possibly return to work. And you need also to plan how you would stop the treatment if this would become necessary. Next slide. We are fully in line with this. This is the West Australian guidelines. The College of GP has written very similar guidelines, and there is a joint document of physicians, GPs, psychiatrists, and pain specialists, and I hope you are familiar with some of these. Possibly the CDC guidelines are the ones which are most up to date, and you can easily download them from the net. But what is really important is that you need to follow guidelines if you want to use opioids, and please use opioids only in very selected cases and only if you improve function. Next slide. In our guidelines, we are saying you need to exclude mental health, alcohol, and other drug dependency issues. You need to have a pain diagnosis, and the pain diagnosis should be defined nociceptive mechanical or neuropathic pain. It should not be nociplastic pain and central sensitization. You should always do a trial, and you should never use opioids in headaches, migraine, fibromyalgia, chronic visceral pain states, and other central sensitization disorders. Next slide. So I come to a conclusion here. I think there is no question that opioids are necessary to treat acute pain, but opioid-sparing multimodal analgesia is even needed there. In chronic pain, the role of opioids is limited in view of the socio-psychobiomedical nature of chronic pain and the central sensitization component of chronic pain. Current overuse of opioids in the setting of chronic pain has led to poor treatment of chronic pain. These patients are on opioids, but they are not functional. They are actually more dysfunctional as if they wouldn't be on opioids, and increased risk of abuse, diversion, and overdoses with the mortalities you have seen. Therefore, if you want to use opioids in chronic pain, you should limit the use and follow strict guidelines. And in particular, you should always have a way out of using an opioid by making clear in the very start of your conversations with the patients that this is a trial, and if the trial fails, you have actually to abandon opioid treatment. And last but not least, I want to emphasize that there are opioids and opioids, and there are atypical opioids which are more harmless and more effective in chronic pain, and these are transdermal buprenorphine and tramadol and tapentadol, because we know for buprenorphine that it has not many of the risks of other conventional opioids. It is not suppressing androgen depression in the same way as opioids is doing. There is a reduced risk of fatal overdoses, and the atypical opioids tramadol and tapentadol, which also interfere with noradrenergic and serotonergic pathways in the case of tramadol, and noradrenergic pathways in tapentadol, are the ones where it could be shown that these are truly improving the quality of life and function of chronic pain patients, and that is possibly because these mechanisms of action are targeting central sensitization and are therefore by far more appropriate for the treatment of chronic pain. So I would encourage you all, if you decide that one of your chronic pain patients is needing an opioid, then stick to these 3 opioids. This is exactly what my pain clinic is doing here in Perth, and what we are also trying to achieve by rotating patients who are referred to us on other opioids to one of these 3 opioids. Thank you very much for your attention. My apologies for the problems with the slides. And I wonder if we have time for questions now and how this will be managed. Thank you very much.
Yep, so if anyone has any questions, all microphones have been unblocked. feel free to ask questions.
So,
I wanted to know, I'm one of the Flinders doctors. Do you recommend for patients who come to us sort of quite a few patients who are post like hip replacement, have got pain for months leading up to and quite a while after, instead of the endone PRN using like tramadol PRN?
Sorry, I couldn't hear you very well. There are lots of funny noises in there.
Do you recommend using tramadol as a PRN opioid for patients with sort of acute on chronic pain instead of endone?
Yes. Our approach is that our first line immediate release opioid for treatment of all acute pain, even in the hospital, and acute on chronic pain is tramadol 50 milligram immediate release PRN. We would love to use tapentadol immediate release because you would get less nausea, vomiting, and problems with serotonin reactions, but regrettably, immediate release tapentadol is not on the PBS yet, and that causes a problem. But we are trying at the moment, at least in hospital, to get tapentadol on the formulary immediate release because that would be even better than tramadol. But the risk of using endone PRN for longer periods of time is that patients like the feeling and you have actually a risk of causing abuse or dependency with this approach.
Thank you.
Does anyone else have any questions?
No.
Oh, yeah, just one. Do you have an upper limit in terms of age groups you use tramadol or tapentadol in?
Yeah, I mean, for tramadol, one has to be careful in elderly patients because they are more sensitive to the serotonergic symptoms. For tapentadol, there are very good data with patients in the age range 65 to 85, where it is actually extremely effective with minimal adverse effects. And a lot of geriatricians I know are now recommending tapentadol slow release, which is on the PBS, as their opioid of choice in elderly patients. With tramadol, you have to be more careful.
About management of those two things. So this is a typical adolescent unexplained or complex widespread pain presentation. So persistent pain is any pain from any cause, organic, non-organic, mixed, for over 12 weeks. And then we get our non-specific pains, which some people call medically unexplained pain, which is part of a broader group of medically unexplained symptoms, which can often be very disabling and quite a substantial functional problem in adolescents and young adults. But for the pain group, it tends to be chronic daily headache, fibromyalgia, non-specific lower back pain, and then a non-specific set of musculoskeletal pain symptoms, which are often widespread. So typical mixed pain presentation with joint pain, with fibromyalgia, muscle pain, some soft tissue pain, and I think the hair colouring in is actually headache. So when we look at our tertiary pain clinic at the Children's Hospital, this is actually the pain team rather than the rehab team, but we work very closely together. They had 544 persistent pain presentations in a year, I think was 2015. And 20% of those children were children that were known to already have a disability. That was a mixture of physical disability, so your neurological disabilities, as well as autism and intellectual disability. The commonest pain, the age at presentation was 14, so we tend to see complex pain problems emerging in adolescents. They're uncommon in children, slight predominance of girls, and the neurological populations were different. So the third of the disabled population was cerebral palsy. They predominantly had lower limb pain. And they were post-orthopedic surgery, spasticity management. So they had a upper motor neuron sort of driven pain presentations, but they were in the pain clinic because they were persistent and disabling, and they would have been passed to the pain service if they hadn't responded to spasticity treatments. And the non-CP population were predominantly back pain, so more of a musculoskeletal presentation. I look after a lot of kids who have double jointedness, and that seems to be a strong predisposition to complex, widespread, persistent pain problems, as well as depression, anxiety, and the 25% of the pediatric population were hypermobile. So people are born more flexible, and you can score hypermobility, work out whether someone's in the normal or abnormal range. So this is the score, whether people can get their thumb to the inside of their arm, 90 degrees of hyperextension at the MCP, hands flat on the floor with legs straight, elbows hyperextend to more than 10 degrees, and knees hyperextend past 10 degrees. So 10 degrees of extension past neutral. So past 10 is abnormal. Scores of 6 of these, so 4 are bilateral, 6 is abnormal in a child, 5 in an adolescent, and 4 in an adult. So if you look at your pain populations, there's probably a reasonable subgroup who have this congenital flexibility that seems to be a bit of a driver. So I'm going to talk about a couple of cases to make it more practical. My understanding was the previous speaker spoke more about some of the science and the pharmacology and physiology. This young fellow is 15 years old. He has hip and lower back pain. He was born with a complex, rare genetic condition that resulted in bone fragility and fragility fractures, so multiple fragility fractures and some vertebral crush fractures, alongside some other structural anomalies, so heart, hearing and visual impairments, and he has a mild intellectual impairment. So he describes his pain as stabbing and sharp. The pain scores, we use pain scores all the time with people with intellectual disabilities or limited cognitive capacity. There's a pediatric score, which is facial expressions rather than numbers. So if you have someone with an English as a second language, so you just need to make sure, even though the pain score is fairly simple, that the patient that you're dealing with does understand what you mean and can give you a meaningful answer. Sometimes I make it really simple and ask them whether they're in mild, moderate, severe pain. Mild pain 0 to 4, moderate pain 4 to 8, severe pain 8, 9, 10 or 9, 10. His pain was hips and back. These are all previous fracture sites, previous surgical sites, and he's describing constant pain. He had happened to go straight to opiate-based medication. I'm not sure quite how that happened, but we'll talk about medication management later. So he was on oxycodone and Targin, which is a sustained release. He had some local techniques and used distraction and found his pain was worse with weight bearing. So he'd already had our bone fragility interventions, bisphosphonate, physical rehabilitation, so lots of physiotherapy, episodic physio, post-fracture, post-orthopedic surgery. He was a wheelchair user in the community, so he was a household walker wheelchair community, and he'd had all of his lower limb long bones had intramedullary growing rods, we call them FD rods, to support his bone density. He finds it hard to get off to sleep and uses some techniques to get off to sleep, but his pain was interfering with his sleep, and pain was significantly interfering with his school. So he missed 20 days of school. One of the useful things about school and pediatric practice is the schools tell the families exactly how many days have been missed, so you can actually use that as an outcome measure. It's quite a useful outcome measure for function. He was already struggling at school, but he did quite enjoy being there. He's a very social boy. So school was a positive place for him, and he did recognise that school was a good distraction, and he was more able to function with his pain, with people around him, with the activities of school. He had long-term not done the physical education in school. So one of our challenges with rehab and younger people is that they're expected to be physically active as part of their PE classes, so it's part of their vocation. But we'd already arranged, because of his limited mobility, not to do that with him. And he had a breakout room, a timeout space, if he wasn't going well. So one of the issues that had cropped up is that he'd started to get some mood changes. So adolescence is quite a vulnerable time, and it seems to be it's a particularly vulnerable time for young people who are growing up with a disability. He'd become more and more anxious. So his severe anxiety about injury is catastrophizing. So the pain psychologists talk about catastrophizing. So he's so worried about sustaining another fracture, which was in his context of severe bone fragility, only partially responsive to treatment. That's a reasonable worry. That's a founded fear. But his extreme worry was starting to impair his function, and it was probably playing into pain sensitization. He was having some difficulty with interpersonal relationships, and his mood rating is probably moderate. So it would have been better to get a formal scoring system for mood. So DAS you can use from 14 up, which would have been a good choice, but he's at risk. So he'd had a progressive decline in function, which was also probably playing into his pain and his mood and his difficulty. So he was already on the downhill, and had persistent pain that was increasingly disabling as his mobility was changing. And he talked about loss of function being one of his reasons for sadness. So he had a little bit of family complexity. So with the pain patients, in fact, anyone with a disability where you're trying to make functional gains, the social supports are really important, the family environment, the context of how supported that young person is. And we can get often get blended families, but a blended family can function well. So it's really about the detail. Do you feel supported by your family? If you ask for help, would you get help? If you needed someone to get you some more, take you to the doctor, would that happen? And he was starting to get some posturing. So we can get some persistent pain presentations that end up with an element of functional dystonia, where the pain seems to trigger some abnormal motor patterns. And he was very tender and had limited ranges, but that's probably more orthopedic. So he was also hypermobile, but very lax. So some of the kids with rare cementous laxity, which can cause instability problems, so subluxation, dislocation. So the plan for him was to change his pharma medicine from primary opiate-based treatments to Panadol, Nurofen, essentially, to continue his physiotherapy, so to try and aim for some physical rehabilitation. The pain team added in TENS. I'm not so sure about the efficacy of TENS, and the evidence base is quite weak. But often the kids like to do something active. And then some simple measures, so simple measures in education from a psychological perspective, while the psychological assessment was in progress. So I'm just going to talk briefly about non-specific lower back pain. So this fella actually had vertebral crush fractures, so had a reason for his back pain, which was somewhat responding to bisphosphonate. So non-specific lower back pain is one of our major causes of disability in working age young adults. So it increases through adolescence to be the commonest cause of disability in adults. And it's a space that's primarily managed in primary care, but I think there's a strong rehabilitation role. If you're interested, there's a recent article in the Lancet, which was like a educational article, which it goes through all the current evidence about non-specific lower back pain and the management evidence, which is excellent. It's in this week's issue, I think. So that even the acute back pains rarely have a specific cause, but there are a few red flags, which you guys should all know about. The spondylolisthesis is pars intra-articularis fractures, which is an adolescent phenomenon, particularly. So risk factors for non-specific lower back pain, female, tall, psychological distress. So there's a persistent pain and depression relationship, which is quite strong. And smoking, and the things that are in the media, particularly for adolescents, screen time and the weight of the school backpacks, were actually not associated in moderate studies, nor was physical activity status or fitness. So either high or low levels of fitness weren't associated. So I'm just going to go on to talk about another case with a more non-specific presentation. So this young person was primarily presented with headaches. She had more of a variable pain picture, so more of a pain that came and went. And she talked about bitemporal headaches particularly, and persistent headaches. She was on a more appropriate regime to start with, simple analgesics, amitriptyline, and tried some local measures as well. And she didn't have any red flags. So no visual changes. The medico-legal trap with headache in young people is benign intracranial hypertension, which can cause visual field loss, and has been a common medico-legal. She had weight gain, so would be vulnerable for benign intracranial hypertension, but her headaches weren't associated with sleep. So she was on melatonin, despite the fact she had no issues with initiating sleep, and she was waking with a headache. She was a high-performing school student and had a substantial functional loss, so missed a lot of school, but was managing schoolwork at home. Again, put in place measures at school to allow her to manage to function and be confident to go with the headaches. And again, a low mood with a trigger of the disabling nature of the headaches. And it's a relatively resilient and persistent. There's often a family history of there can be a family history of complex pain problems, and that's a really challenging situation. So he'd had ophthalmology with normal findings, and again, the physical examination is important to do. It's important to do to demonstrate to the patient you're doing it, to show them that you're interested and you're being thorough, and for key negative findings, essentially to rule out any missed pathology. And he didn't have craniocervical headaches. He didn't have a trigger from his neck, and wasn't hypermobile. So he was encouraged to increase his activity and do some psychology. So starting off with some self-directed. So the treatments that have been shown to be effective in so once you've gone past specific treatments for specific causes of pain, like spasticity, which I'm not going to talk about, the treatments that have been demonstrated to be effective for persistent non-specific pain are education. So the education doesn't have to be one-on-one. I think it helps that if you spend some time with these patients, you're more likely to be able to build a useful therapeutic relationship and start to get them moving forward, but you can give them resources. So there's some awesome resources from the Newcastle team. The chronic pain cartoon explains about the nature of pain, central pain sensitization, Laura Mosley, who's an academic physiotherapist, has done lots of work on non-specific pain and musculoskeletal pains. His resources are really interesting. He's a great presenter, and they're widely available on the internet. And then the New South Wales ACI have done a website called Pain Bites, which is a self-education website, and it's got a specific youth section and a specific spinal cord injury section. I think they're adding an older adult section, but they keep adding more specific targeted groups. So all of those resources patients can use directly themselves. So the nature of the exercise is important. It needs to be graded exercise, it needs to be progressed, and it needs to be about function. So the patients won't get better if they're lying on a bed having massage. They won't get long-term functional gains. In the exercise activity, I try and include schoolwork, vocation, so to get a progressive return to meaningful activities. And then, although people do like passive modalities, and the quote being patients prefer passive treatments, they're generally helpful in the short term and don't give you long-term improvements. But some patients do use them, and if they give you short-term improvement and allow the patient to do their rehab or start working through their program, then that's great. I think manipulation is currently a minefield. One of my recent cases was a young girl who had 4 weeks of excruciating back pain, had fevers, had weight loss, had tachycardia, was sweaty, and she had a lymphoma, and the chiropractor had completely missed all the red flags. Yeah, so it needs to be with care. So the other thing I was going to talk about, which I think is particularly important to pain, these non-specific pain patients, is the therapeutic alliance. So this is a little bit about interdisciplinary working, and it's a little bit about the art of medicine, not the science of medicine. So therapeutic alliance is a sense of collaboration between the client and the therapist, and this is equally applicable to medical practitioners. And it's not just liking the patient, it's being able to build an effective working relationship with the patient. And I think one of the key things we can do in rehab is actually build an effective therapeutic relationship with the patient, and then include the team of allied health professionals in that relationship without them all having to individually rebuild that relationship. So this is from a piece of work that one of my main research collaborators, Roger Adams, did, and I think it's a really interesting piece of work. It was a study that was within a study of lower back pain treatments, so looking at passive manipulation and active physiotherapy treatments, but they looked specifically at this relationship between the therapist and the patient as well. And they found the main components were goal setting. We've all heard this before. That the therapist or the rehab team and the patient agree on the interventions that they're going to undertake. So I think if you get someone coming in as a pain patient and they just want opiate-based medication, that's an extremely difficult conversation to have. But in my practice, I would say to them, look, I am a rehab physician. I can help you with rehab. Rehab has been shown to be effective in this situation. That's what I do. And yeah, so there is there's a third component, which is about how you actually get on, particularly with the therapist who spend a lot of time with the patients. And if you have a really strong therapeutic alliance, you can be using a weaker treatment and still get good outcomes. So this was a little bit about the study. So it was a randomized controlled trial to see exercise programs, so general reconditioning, motor control, so the back school type of program, or manipulation. And they got, when they put all of the groups together, so treatment that is probably reasonably effective, the back school probably more effective, and manipulation thought not to be effective. So they put all 3 groups together. If there was a strong therapeutic alliance, there were better outcomes for function, pain, and disability, which is what we're after. So for psychology and persistent pain management, with my adolescents, I worry. So I use mental health instruments like DAS to try and ascertain exactly what I am treating with the psychology. So there are practical psychological support that helps with persistent pain, primarily lifestyle management, so pacing, stress minimization, healthy lifestyle. So trying to develop that patient's self-management skills, self-efficacy, resilience, trying to work on any additional stresses around them. And then there are the out and out CBT strategies for depression, anxiety. There's new good clinical practice guideline in the MJA for depression, primarily in primary care, but it's so common in rehab, it's probably worth the read. But first line for mild and moderate is the non-pharmacological. It's only when you get moderate to severe depression that they now recommend you add in an antidepressant, starting with the SSRIs. I tend to use amitriptyline first because of its pain effect, but I think you just need to be aware that it might be working as an antidepressant. It probably is working as an antidepressant. So this is what the psychologists are trying to do, trying to take people away from the circle on the left-hand side, so the pain-related fear, catastrophizing, avoidance behaviors, to still having the pain. So the psychologists and probably everybody can't treat the pain. So when we talk to patients about function first, we're probably not going to change your pain very much, but we can get you back to normal. We can make things feel easier. We can get you, back into school, exercising again. Eventually, I do say with adolescents, I think there's fairly good prognosis. So I talk to them about the pain eventually settling with time. But I talk a lot about it becoming easier to manage, and it might be a presence for them, but not something that's interfering. And the reason we worry particularly about psychological symptoms in chronic illness and disability in children is because it's depression particularly is very disabling. And it's our leading cause of death in our adolescents now. So for pharmaceuticals, with paediatrics, we always tend to be a bit more conservative with our prescribing. So we use simple analgesia for the WHO ladder. Panadol's just been shown in the Lancet review on lower back pain, is thought to be not effective in adults. But we do use Panadol, non-steroidals, and then amitriptyline and gabapentin. I've been largely underwhelmed with gabapentin for non-specific pain rather than neuropathic pain, but you get an occasional responder. And opiates, although they're excellent in a perioperative situation, there is actually no evidence out there that they have any lasting efficacy. So opiates have a problem called tachyphylaxis, which means that if you take opiates for long enough, you get more opiate receptors and then they stop working. So then you then have to start escalating doses. There was a really nice study in the JAMA recently with veterans in the US where they did a head-to-head with opiates and a non-opiate-based strategy for osteoarthritis, hip knee, osteoarthritis and lower back pain. So the non-opiate strategy was Panadol, non-steroidals, and then amitriptyline or gabapentin. But it was pragmatic, so it was open and it was clinician discretion, and there was no superiority. So the opiate group had the same, the pain reduction was the same in the opiate and the non-opiate group, but the functional outcomes were slightly better in the non-opiate group. So this is my opiate, this is my don't go there opiate graph. So this is the number of opiate prescriptions in the USA in these, so you see the years along the bottom. So there were 253 million people in the US in 2013. So I don't know what happened to the other 40 or so million people that missed out on their opiate prescription, but they were getting to the point where almost like a crazy amount of the population. So some of these prescriptions will be lots of prescriptions on single individuals, but that's a lot of opiate prescribing. So with what's the rehabilitation role in the non-specific pain syndromes? So I think there is a strong rehab role. Like we have obviously rehab clinicians running pain clinics, but there's a strong rehab role. So coordinated interdisciplinary management with goal setting, with regular rehab progressions, including some simple analgesia in lower back pain. So particularly in patients who've not responded to education and exercise in the community under their GP, and in the group that are substantially functionally disabled by their pain. And that's it for me. Any questions? Hello.
Thank you, Louise. Please unmute your microphone if you have any questions. Feel free to ask them. Alternatively, if you want, you can type them into the chat function and I will announce them. Does anyone have any questions? Oh, we have one. Oh, sorry. So it appears. Thank you so much, Louise, for your presentation today.
No worries. Sorry, it was the Wi-Fi didn't work. I'll send you the slides so you've got the resources.
No worries. Thank you so much.
No worries. Thanks, Terence.
Thank you, everyone. Bye.